Welcome to critical care nursing and renal nursing. These are the common questions that was tested between the period January to April 2025. Right? So let's get right into it. Question number 1. A client who was found unconscious at home is brought to the hospital by a rescue squad. In the intensive care unit, the nurse checks the client's oculocephalic response by this is the doll eye. The doll eye. You do it by turning the client's head suddenly while holding the eyelids open and to elicit the oculocephalic response, which normally detects cranial nerve compression. The nurse has to turn the client suddenly while holding the eyelids open. Normally, the eyes will move from side to side when the head is turned. In an abnormal response, the eyes will remain fixated. The nurse introduces ice water into the external auditory canal when testing the oculovestibular response. Normally, the client's eyes deviate to the side of the ice water introduction. The nurse touches the client's cornea with a wisp of cotton to elicit the corneal reflex response, which reveals brainstem function. Blinking is the normal response. Finally, shining a bright light into the client's pupil helps evaluate brainstem and cranial nerve 3 function. Normally, the client's pupil responds by constricting. Question number 2 is that the nurse is assessing a 48-year-old with a history of smoking. The client who exercises regularly reports having pain in the calf during exercise that disappears at rest. Which finding indicates that the nurse should further assess the client? The ankle brachial index of 0.65. This one suggests moderate arterial vascular disease in a client who is experiencing intermittent claudication. A Doppler sound is indicated for further evaluation in this case. The bradycardic heart rate of 57 is acceptable in an athlete client with normal blood pressure. The SpO2 is acceptable. The client has a history of smoking. Number 3 is that a client is in hypovolemic shock. In which position should the nurse place this client? Hypovolemic shock. We are supposed to put the patient in supine with legs elevated at 15 degrees. Client with hypovolemic shock is best positioned in supine in bed with feet elevated 15 degrees, and this is to bring peripheral blood into the central circulation. Neither semi-fowler's position nor the supine position by itself promotes venous return. For the semi-fowler position, this one will not facilitate venous return, but it will be helpful for a patient with breathing challenges. Trendelenburg position normally inhibits the respiratory expansion and possibly causes increased intracranial pressure. That's why it is unrecommended for patients with shock. Question number 4, a client comes to the emergency department with status asthmaticus. The client's respiratory rate is 48 breaths per minute and the client is wheezing. An arterial blood gas analysis reveals a pH of 7.52, a partial pressure of arterial carbon dioxide of 30 millimeters of mercury, and a partial pressure of oxygen of 70 millimeters of mercury, and lastly bicarbs of 26 milliequivalents per liter. What disorder is indicated by these findings? All right. We have here respiratory alkalosis, and you can look at the pH is closer to 7.45, so it's a base compared to the partial pressure is partial pressure of carbon dioxide is 30, so it is closer to 35, which is a base. So the problem is emanating from the lungs. Remember, respiratory alkalosis normally results from alveolar hyperventilation, and it's marked by a decrease in partial pressure of carbon dioxide to less than 35 millimeters of mercury and an increase in blood pH of over 7.45. Metabolic acidosis is normally marked by a decrease in bicarb to less than 22 milliequivalents per liter and a decrease in blood pH to less than 7.35. In respiratory acidosis, the pH has to be less than 7.35 and the partial pressure of carbon dioxide must be greater than 45 millimeters of mercury. Lastly, in metabolic alkalosis, the bicarbs has to be greater than 26 and the pH has to be greater than 7.45. The next question is that the nurse auscultates the lungs of a client who has been diagnosed with a tumor in the lung and notes wheezing over one lung. What additional assessment should the nurse make? Wheezing. You have to look at the obstruction of the airway. You know, wheezing over one lung is the presence of in the presence of a lung tumor is most likely to cause obstruction of the airway. So exudate will be more likely to cause crackles. The client's history of smoking will not cause unilateral wheezing. Pleural effusion will produce diminished or absent breath sound, and that makes it wrong option for that. The nurse is caring for a client with end-stage kidney disease. What arterial blood gas results are most likely associated with this disorder? All right, the kidney is responsible for the secretion of the hydrogen ions for elimination. So if there is a disorder, it's not functioning, so the body is going to retain more hydrogen, it is going to be more acidic, and out of the options that we have, the first one is the one that is able to show that. So and normally metabolic acidosis occurs in end stage kidney disease because the kidneys are unable to excrete increased loads of acid. So decreased acid secretions result from the inability of the kidney tubules to excrete ammonia and to reabsorb sodium bicarbonate. There is also decreased excretion of phosphates and other organic acids, and thus the results. A nurse just received a shift report for a group of clients on telemetry unit. Which client will the nurse assess first? So here we are looking at prioritization, and in prioritization, a client admitted with first degree and atrioventricular block whose cardiac monitor now reveals type 2 is complicating. So we are supposed to look at that patient. So this one shows that this client should be assessed first. The client's rhythm has deteriorated from first degree block to type 2 second degree AV block and may continue to deteriorate into a lethal form of AV block that is known as the complete heart block. So the client who underwent cardioversion 2 days ago has likely had the underlying reason for the sustained ventricular corrected. A client with a history of heart failure may have chronic basilar crackles and pitting edema of both feet as the normal symptoms. Therefore, assessing this client first is not really necessary. The client who underwent PCI with standing was at risk for reperfusion arrhythmias and or bleeding from the arterial puncture site, but could be considered to be stable 24 hours post this was the procedure. The nurse is caring for a client with multiple organ failure who is in metabolic acidosis. Which pair of organs are responsible for regulatory processes and compensation? Compensation, we talk of the lungs and the kidneys because these organs facilitate the ratio of bicarbonate to carbonic acid. Carbon dioxide is one of the components of the carbonic acid. The lungs regulate carbonic acid levels by releasing or conserving carbon dioxide by increasing or decreasing the respiratory rate. The kidneys assist in acid-base balance by retaining or excreting bicarbonate ions. The nurse is caring for a client in the post-anesthesia care unit following adrenalectomy. What is the nurse priority action? You need to assess the blood pressure. As you know, removing a major source of adrenal hormones may cause a state of temporary adrenal insufficiency. So after an adrenalectomy, the client is usually sent to a critical care unit. Immediately after surgery, the client should be assessed every 15 minutes for shock due to possible insufficient glucocorticoid replacement. Assessment is a priority over intervention. You need to assess the blood pressure, then electrolytes. Finally, you assess the client for fluid replacement and pain management needs. Next question is, a nurse is assessing a client for tracheal displacement. Should know that the trachea will deviate towards the it will deviate contralateral side in a hemothorax. Remember, the trachea will shift according to the pressure in gradients within the thoracic cavity. Like in tension pneumothorax and hemothorax, accumulation of air or fluid causes a shift away from the injured side. So if there is no significant air or fluid accumulation, the trachea won't shift. Tracheal deviation towards the contralateral side occurs in simple pneumothorax when the thoracic contents shift in response to the release of normal thoracic pressure gradients on the injured side. The nurse is caring for a client with a left chest tube to drain a pleural effusion. The nurse notes that the water is below the required level in the water seal of the closed chest drainage system. What is the priority assessment that the nurse needs to make? He needs to evaluate the client for the presence of a pneumothorax. Remember, atmospheric pressure is greater than the pressure inside the pleural space. So without the necessary amount of water in the water seal chamber, air will enter the pleural space, resulting into pneumothorax. The water seal does not affect the amount of suction used. So the water seal is separate from the drainage collection chamber. The collection apparatus should be kept below the level of the chest to facilitate drainage. However, this will not affect the level of water in the water seal chamber. A black client is admitted to an acute care facility with the diagnosis of stroke. Their history reveals bronchial asthma, exogenous obesity, and iron deficiency anemia. Which history finding is a risk factor for stroke? For stroke, being obese is a risk factor. Other factors include a history of ischemic episodes, cardiovascular disease, diabetes mellitus, atherosclerosis of the cranial vessels, hypertension, polycythemia, smoking, hypercholesteremia, hormonal contraceptive use, emotional stress, family history of stroke, and advancing age. The client's race, gender, and bronchial asthma are not risk factors for stroke. The nurse is assessing a client whose blood pressure is dropping and heart rate and respiratory rate are increasing, which finding indicates the client is at risk for hypovolemic shock, severe hemorrhage, right? Severe hemorrhage. So we have external fluid loss such as the hemorrhage, internal fluid shifting such as ascites, severe edema, and dehydration could lead to hypovolemic shock. Massive vasodilation is normally the initial phase of vasogenic or distributive shock, which can further be subdivided into three types. We have the septic shock, neurogenic shock, and anaphylactic shock. A severe antigen-antibody reaction occurs in anaphylactic shock, while the gram-negative bacterial infection is the most common cause of septic shock, which is one of the vasogenic types. Loss of sympathetic tone that leads to vasodilation will occur in neurogenic shock, which is still a subtype of distributive shock. The family of a client receiving a hospice care takes a dinner break only to learn that the client died while they were absent from the bedside. What should the nurse do to console the family at this point? You just need to stay with the family while they view the body. The family may go to great lengths to ensure that their loved ones will not die alone. However, despite the best intention and efforts of the family and clinicians, the client may die at a time when no one is present. If the client dies while the family members are not present, the family may express feelings of guilty and will need emotional support. This will be provided by staying with the family while they view the body. Even though the time of death cannot be predicted, some clients appear to wait until family members are away from the bedside to die. The family does not need to hear how the client is no longer in pain and at rest. The family needs emotional support. The family should not be permitted to feel guilty for leaving the client. The family should take rest periods away from the bedside in order to provide the best support to their client. A patient is on a medical ventilator, mechanical ventilation, which has been effective in treating oxygenation problems secondary to hypovolemic shock. When developing the plan of care for this patient, which nursing diagnosis should the nurse consider to be a priority at this time? At this time, we fear infection, guys. Right? We fear infection. The priority nursing diagnosis for a client on medical ventilation, especially following hypovolemic shock, is indeed risk for infection. Mechanical ventilation normally increases the risk of ventilator-acquired pneumonia, which is a significant concern in such patients. Hypovolemic shock compromises the immune system, further heightening the risk of infection. The patient may also have invasive lines such as central venous catheters, which are additional sources of potential infection. While other diagnoses like impaired gas exchange and risk for impaired skin integrity are valid consideration, the effective management of oxygenation through ventilation reduces the immediate priority of this diagnosis. Preventing infection becomes paramount to avoid complications like VAMP. A client recovering from a drug overdose is interacting with the nurse and recounting their exploits at numerous parties they attended. Which action is the most therapeutic? You direct the conversation to more realistic concern as a nurse. The nurse has to direct the conversation to realistic concern or issues to decrease denial and focus on rebuilding a substance-free life. Allowing the client to continue with the stories or questioning the clients further about their exploit reinforces the denial. The nurse telling the client they have heard the stories before is non-directive. Additionally, this action do nothing to help the client focus on rebuilding a substance-free life. A client has had a cardiac catheterization. The femoral dressing has a bright bloody drainage. What should the nurse do first? He has to apply the pressure at the site to control bleeding. Moderate amount of blood drainage could indicate active bleeding. So the priority action is to apply pressure to the area and call for help. Assessing the airway or pulse or administering oxygen will not be able to address the problem at this case, which is bleeding. Which statement regarding heart sound is correct? Heart sounds. S1 is held loudest at the apex, and S2 is held loudest at the base. S1 sound is the lump sound and is loudest at the apex of the heart. It sounds longer, lower, and louder there than the S2. S2 is the dub sound and is highest at the base. It sounds shorter, sharper, higher, louder there than the S1. A client is in the oliguric phase of acute kidney injury. For which risk should the nurse assess the client for? Oliguric. Yes, pulmonary edema. Remember, pulmonary edema can develop during oliguric phase of acute pulmonary failure, renal failure because of decreased urine output and fluid retention. Metabolic acidosis develops because the kidneys cannot excrete hydrogen ions, and bicarb is used to buffer the hydrogen. Hypertension may develop as a result of fluid retention, while hyperkalemia develops as the kidney lose their ability to excrete potassium. For a client with hyperglycemia, which assessment finding best support a nursing diagnosis of deficient fluid volume? Hyperglycemia, deficient fluid volume. Deficient fluid volume. And this is, we have the increased urine osmolarity. In hyperglycemia, urine osmolarity, that is the measurement of dissolved particles in urine, increases as glucose particles move into the urine. The client will experience glycosuria, polyuria, losing fluids, and experiencing deficient fluid volume. The cold, clammy skin, that is the jugular vein distension, and a decreased serum sodium level are signs of fluid volume excess, and the opposite imbalance. A nurse is assisting the healthcare provider with the removal of the central venous access device, CVAD. What should the nurse do to prepare the client? You need to instruct the client to take a deep breath and hold it, right? So the client has to perform the Valsalva maneuver during the insertion and removal of this CVAD. This increases central venous pressure during the process and prevents air embolism. Tilted back position is the preferred position for CVAD insertion and removal. If not possible, a supine position is sufficient for CVAD removal. The client should hold their breath, not exhale. A client is admitted to an acute care facility with suspected dysfunction of the lower brain stem. The nurse should monitor the client closely for hypoxia. Lower brain stem dysfunction alters bulbar functions such as breathing, talking, swallowing, and coughing. Therefore, the nurse should monitor the client closely for hypoxia. Temperature control, vision, gait aren't lower brain stem functions. The nurse assesses a client with a 5-inch by 2-inch stasis ulcer just above the left malleolus. The wound is open with irregular, reddened, swollen edges, and there is a moderate amount of yellowish tan drainage coming from the wound. The client verbalizes pressure type, pain, and rates the discomfort at 7 on a scale of 0 to 10. What is the primary nursing goal for this client? You need to keep the pressure of the bed linen off the area. The nurse should keep linens off the stasis ulcer to decrease the amount of pressure that the linens exert upon the lower extremity and prevent further tissue injury. Administering prescribed analgesics will be an intervention for reducing the pain. Applying lanolin lotions to the left ankle ulcer will not promote healing. Encouraging client to sit up in a chair 4 times per day is an intervention to promote activity. The nurse will elevate the involved extremity while the client is sitting up to reduce venous stasis and capillary pressure. A client is caring for several clients on an oncology unit. Which client should the nurse assess first? The client with the white blood cell of 2000. A white blood cell count of 2000 puts the client at greatest risk for infection. The nurse will want to see this client first in order to reduce the transmission of bacteria and other organisms from working with other clients. The client on the bed rest can wait and other clients are stable. We have a client with metastatic brain cancer is admitted to the oncology floor. What action will the admitting nurse take regarding to an advanced directive for this client? They have to inform the client or the legal guardian of the right to execute an advance directive. All clients have a right to execute an advance directive. The admitting nurse will ensure that the client is aware of that right. The facility's ethics committee can decide on a treatment plan if the client is unable and a healthcare power of attorney has not been appointed. The facility employees are not required by law to respect an individual's moral rights. However, the healthcare professional should respect the client's individual rights as part of professional responsibility. While a client may refuse medical treatment via an advance directive, the nurse will not advise this. The nurse evaluates the effectiveness of the client's postoperative plan of care. Which outcome is expected for a client with an ileal conduit? The client will empty the drainage pouch frequently throughout the day. Remember, it's important that the client empties the drainage pouch throughout the day to decrease the risk for leakage. The client does not normally need to curtail physical activity. Aspirin should never be placed in a pouch because aspirin can irritate or ulcerate the stoma. The client does not catheterize an ileal conduit stoma. The nurse should assess the client with severe diarrhea for which acid-base balance, metabolic acidosis. Client with severe diarrhea loses large amounts of bicarbonates, resulting into metabolic acidosis. Metabolic alkalosis does not result in this situation. Diarrhea does not affect the respiratory system. A nurse is caring for a client who had a stroke. Which nursing intervention promote urinary continence? Encouraging intake of at least 2 liters of fluid daily. This will help the client's bladder, therefore will promote bladder retaining by stimulating the urge to void. The nurse should not give the client soda before bedtime. because soda normally acts as a diuretic and may cause the client incontinent. The nurse should take the client to the bathroom or offer the bedpan at least every 2 hours throughout the day. Twice per day is insufficient. Consultation with a dietitian won't address the problem of urinary incontinence. While auscultating the epical heart rate, the nurse notes an irregular heart rhythm at the rate of 120 beats per minute. What should the nurse's next action? You need to assess the pulse deficit. Now, the correct landmark for obtaining an epical pulse is the left fifth intercostal space in the mid-clavicular line. The nurse measures the apical radial pulse for a deficit. This is apical rate minus the radial rate. A deficit is present during atrial fibrillation and premature ventricular contractions because some heartbeats do not perfuse to distal areas. The client should not perform the Valsalva maneuver without electrocardiographic monitoring and the healthcare provider at bedside. Assessment of the underlying disorder should be first to direct the proper intervention. Prior to calling healthcare providers, the nurse should report vital signs and presence of a pulse deficit. Which client should the nurse prioritize to assess first? The client with end-stage renal disease just admitted the night before, because this client is at risk of significant anemia because the kidneys are normally responsible for erythropoietin production. The client is also at risk for significant potassium and sodium imbalances. The client with a negative troponin levels and mild chest pain is most likely not having a cardiac event. While the client with a blood glucose of 110 is no longer in danger. A client who is 2 days post-laparoscopic cholecystectomy is also a stable patient. A nurse in the infection prevention and control program is conducting an assessment of infection control practices. The nurse is evaluating the infection control action taken on the unit for a client with a decreased white blood cell count. Which infection control practices that the nurse consider most important for this client? You need to adhere diligently to aseptic technique. The client in this scenario is neutropenic, which places the client at risk for contracting an infection. So all measures of aseptic technique must be used to protect the client. The other options do not provide a complete protection for the client. A water-soluble bihazardous bag is placed in the client in the room of a client in contact precautions. Which item should the nurse place them in this bag? The linen. A water-soluble bag should be used for items that are dry, but when the bag is placed in hot water, it dissolves. So linen should be placed in the water bag for cleaning. Food wrappers and containers can be placed in the regular trash. A water pincher and intravenous fluid will cause the water-soluble bag to disintegrate. 4 patients injured in an automobile accident enter the emergency department at the same time. The triage nurse evaluates them immediately. The nurse should assign the highest priority to which client? The one with maxillofacial injuries and gargling respiration. Emergency department, of course, triage involves employing the emergency severity index, abbreviated AESI, as the triage tool to assess which clients should be seen first and what resources they will need. It is a 5-level algorithm with 1 given to the highest priority. Clients with the poor prognosis are given a lesser priority. Client with maxillofacial injury and gargling respiration needs immediate attention because of an impaired airway, which will be considered a level 1. Spinal cord injury doesn't exhibit immediate airway needs and will be considered level 2. The client with a severe head injury, no blood pressure, has a grave prognosis. Whether the client is in the early labor doesn't surpass airway compromise in importance and will be considered at level 2. A client who has lost control has been put in restraints. Which nursing intervention is the highest priority when a client is placed on restraints? Monitoring client every 15 minutes. Safety of the client and staff is the utmost priority. Therefore, the client must be monitored closely and frequently, such as every 15 minutes, to ensure that the client is safe and free from injury. Assisting with nutrition and elimination, performing range of motion exercise on each limb, changing the client's position every 2 hours are important after the safety of the client and staff is ensured by close, frequent monitoring. What is the nurse expected to do when filling a report about an incident of finding an older adult client with mild dementia on the floor? The nurse must file an incident or an adverse event or report. Nurses who witness the event are responsible for entering that information. Adverse reporting is a mechanism to find persistent problems, and it is confidential and non-punitive. A client is admitted to the emergency department with a history of abdominal aortic aneurysm. The nurse assesses the client with which sign or symptom that suggests that the client's abdominal aortic aneurysm is extending. If they're having increased abdominal and back pain, pain in the abdomen and back signify that the aneurysm is pressing downward on the lumbar nerve root and is causing more pain. The pulse rate will increase with aneurysm extension. Chest pain radiating down the arm will indicate myocardial infarction. Blood pressure will decrease with aneurysm extension, and the respiratory rate may not be affected. A 9-year-old is brought to the emergency department with extensive burns sustained in a restaurant fire. What is the nurse's most important intervention? You have to conduct a wound assessment. Remember, the most important aspect of care for a child with burns is wound management. The goals of the wound care are to speed debridement, protect granulation tissue and new grafts, and conserve body heat and fluids. Antibiotics aren't always administered prophylactically. Fluids are administered IV to replace fluid volume according to the child's body weight. Enteral feedings rather than meals are initiated within the first 24 hours after the burn to support the child's increased nutritional requirements. Which finding will be expected in a client with a chest trauma, respiratory rib fractures, and respiratory acidosis? Of course, they are going to have hypoventilation. This hypoventilation is due to the inability to take due breath because of the pain. So hypoventilation causes build-up of CO2 in blood. Kussmaul respirations are related to abnormal respiratory patterns and characterized by rapid, deep breathing. They are often seen in clients with metabolic acidosis, and hyperventilating will not cause acidosis. The choice rib fractures does not represent any information in this scenario. A client with a terminal illness and an advanced directive identifying no resuscitation dies. Which action will the nurse take before caring for the body? Just need to turn off the intravenous fluid infusion. When preparing to provide postmortem care, all equipment must be turned off before caring for the body. The IV infusion should be stopped. The gown will be removed prior to bathing the body, and then the client's dentures should be inserted to maintain the client's facial features after death. And in a rolled towel is placed under the jaw to keep the mouth closed. However, this is not done before the caring of the body. A client with a head injury is being monitored for increased intracranial pressure. The client's body pressure is 90-60 millimeters of mercury and the ICP is 18 millimeters of mercury. Therefore, the cerebral perfusion pressure is, now we get 52 millimeters of mercury as the cerebral perfusion pressure. We arrive to this by taking the map, getting the map mean arterial pressure, which is the systolic plus double the diastolic, where we get a 70. Then we take now the map minus the the map minus the ICP, so which is 70 minus 18, giving us 52. A client has experienced excessive losses of bicarbonate and has subsequently developed an acid-base balance. How will this lost bicarb be replaced? The renal tubule cells will generate new bicarbs. So to replace any lost bicarb, the renal tubule will generate new bicarbs through a variety of chemical reactions. These nearly generated bicarbs is then reabsorbed by the tubules and returned to the body. The lungs and adrenal glands do not synthesize bicarbs. Excretion of acid compensates for lack of bicarbs, but it does not actively replace it. 24 hours after undergoing kidney transplantation, a client develops hyperacute rejection. To correct this problem, the nurse should prepare the client for removal of the transplanted kidney. Remember, hyperacute rejection isn't treatable. The only way to stop this reaction is to remove the transplanted organ or the tissue. Although cyclosporine is used to treat acute transplant rejection, it doesn't halt hyperacute rejection. Bone marrow transplant isn't effective against hyperacute rejection of a transplant kidney. Methylprednisolone sodium succinate may be given IV to treat acute organ rejection, but it's not effective against hyperacute rejection. In the emergency department, a client with facial lacerations states that the spouse beat the client with a shoe. After the lacerations were repaired, the client waits to be seen by the crisis intake nurse, who will evaluate the continued threat of violence the spouse represents. Suddenly, the client's spouse arrives, shouting a desire to finish the job. What is the first priority of the nurse who witnesses this scene? They should call a security guard and another staff member for assistance. The nurse who witnessed this scene must take precaution to ensure personal as well as client safety, but shouldn't attempt to manage a physically aggressive person alone. Therefore, the first priority is to call a security guard and another staff member. After doing this, the nurse should inform the spouse what is expected, speaking in concise statements and maintaining a firm but calm demeanor. This approach makes it clear that the nurse is in control and may diffuse the situation until the security guard arrives. Telling the spouse to leave will probably be ineffective in their agitated and irrational states. Exploring the spouse's anger doesn't take precedence over safeguarding the client and safety. When planning care for a client who has ingested phencyclidine, PCP, the client's highest priority will be meeting the physical needs, right? You're meeting the physical needs. The highest priority signed is you're meeting the safety needs of a client as well as those of the staff. Drug effectiveness or effects are unpredictable and prolonged, and the client may easily become aggressive and physically violent. After safety needs have been met, the client's physical needs can now be looked at, then psychosocial, then lastly the medical needs can be addressed. The nurse is caring for a client that is experiencing shortness of breath. The client is pale and slight psychomoral cyanosis is developing, which laboratory test best measures the adequacy of tissue perfusion. Arterial blood gas. Arterial blood gas levels includes levels of levels of oxygen in blood and determine the adequacy of alveolar gas exchange. Red blood cell count provides information on the quantity of red blood cells in the system. Pulmonary function test measures lung volume and capacity. So although hemoglobin is the red pigment in red blood cells that carries oxygen, it is not the best measurement of tissue or perfusion. A client in a long-term care facility has assigned a form stating that the client does not want to be resuscitated. The client develops an upper respiratory tract infection that progresses to pneumonia. The client's health rapidly deteriorates and is no longer competent. The client's family states that they want everything possible done for the client. What should happen in this case? The client should be treated with antibiotics for pneumonia. The client has signed a document indicating a wish not to be resuscitated. However, treating pneumonia with antibiotics is not a resuscitation measure. So the other options do not represent the client's right to choice. The nurse is planning care for an older adult with an indwelling catheter who is at risk for septic shock. Which nursing action will be most important for this client? You use a septic technique when caring for the catheter, maintaining asepsis of indwelling catheter is essential to prevent these hospital acquired infections. Preventing septic shock is a major focus of nursing care because the mortality rate for septic shock is as high as 90, particularly in clients who are younger than aged or older than 65. Administering IV fluid replacement therapy, obtaining vital signs every 4 hours, and monitoring red blood cell counts for an increase are not measures to prevent septic shock. A client has a tracheostomy. Which nursing action will prevent complications of suctioning? All right. Maintaining a sterility of the suction catheter. Right? Tracheostomy suction should be limited to 10 seconds. Although a replacement cuff must be at the bedside and it's important to record secretions, this will not prevent complications. Trach suctioning is a sterile procedure and rinsing the catheter will be the priority to prevent infections. A neonate is admitted to the neonatal intensive care unit for observation with a diagnosis of probable meconium aspiration syndrome, MAS. The neonate weighs 4.65 kg and is at 41 weeks of gestation. What will be the priority problem for this neonate? Impaired gas exchange. The priority problem for the neonate with the probable mass is impaired gas exchange related to the effects of respiratory distress. Obstruction of the airway may be complete or partial. Meconium aspiration may lead to pneumonia or pneumothorax. So establishing an adequate respiration rate is the primary goal. Impaired skin integrity is a concern, but establishing and maintaining an airway and a gas exchange is always the priority. Hypoglycemia tends to be a problem for the for gestational age babies, not hypoglycemia. If parents do not express interest or concern for the neonate, risk for impaired parental-infant attachment may be appropriate once the airway is established. The nurse is instructing a client with chronic renal failure to maintain adequate nutritional intake. Which diet will be the most appropriate for chronic? Of course, you do low protein, you do low sodium, you do low potassium. Dietary management for clients with chronic renal failure is usually designed to restrict proteins, sodium, and potassium. Protein intake is reduced because the kidney can no longer excrete the byproducts of protein metabolism. The degree of dietary restriction depends on the degree of renal impairment. The client should also receive a higher carbohydrate diet along with appropriate vitamin and mineral supplements. Calcium requirements remain 1000 to 2000 milligrams per day. A nurse is caring for a client with a central venous catheter who needs a dressing change. The nurse is uncertain about performing the procedure. What action will be the most appropriate for the nurse to do first? You have to review the facility's procedure for the steps to complete. Right? Should apply independent problem solving and clinical reasoning as a first action. This will include reviewing the policy and the procedure. It is likely still necessary for the nurse to collaborate with a colleague or a manager, but independent problem solving should be applied as an initial action. Performing the procedure when uncertainty would lead to a client injury and sharing the uncertainty with the client is inappropriate. The client who requested a do not resuscitate DNR order upon admission to the hospital now states a desire for the medical team to do everything possible to help the client get better. The client is concerned about the DNR order, which response by the nurse is best. It isn't a problem to rescind your DNR order. I let your healthcare provider know your wishes right away. Telling the client that it is not a problem to rescind the order is the best response. The client is allowed to rescind the DNR order at any time. The client makes the decisions about the do not resuscitate order with input from the healthcare provider and does not need to talk to family members. The nurse should not imply a question that perhaps revising the do not resuscitate order will be appropriate than rescinding it. The client has not expressed a concern about feeling discomfort, so it will be inappropriate for the nurse to address that concern. The nurse is caring for a client admitted with pyloric stenosis. An nasogastric tube is placed upon admission is on low intermittent suctioning. Upon reviewing of the client's morning blood work, the nurse observed that the client's potassium is below the reference range. The nurse should recognize that the gland may be at risk of what imbalance? Metabolic alkalosis. Probably the most common cause of metabolic alkalosis is vomiting or gastric suction with loss of hydrogen and chloride ions. This disorder also occurs in pyloric stenosis, in which only the gastric fluid is lost. Vomiting, gastric suctioning, pyloric stenosis all remove potassium and can cause hypokalemia. These glands will not be at risk for hypercalcemia, hyperparathyroidism, and cancer account for almost all cases of hypercalcemia. The nasogastric tube is removing stomach acid and will likely raise pH. Respiratory acidosis is unlikely since no change was reported in the gland's respiratory status. A nurse is caring for a client with multiple myeloma. Which laboratory value is the nurse most likely to see? Multiple myeloma, hypercalcemia. Calcium will be released when the bone is destroyed, causing hypercalcemia. Multiple myeloma doesn't affect potassium, sodium, nor the magnesium levels. Which laboratory test should the nurse monitor while the gland is receiving heparin therapy? Heparin therapy, we have activated partial thromboplastin time, APTT. This is normally used to measure the clotting status when the gland is receiving heparin. The ENR and the PT are used to measure clotting status when a gland is receiving warfarin sodium. So neither heparin nor sodium affects the thrombin time. So some of the short answer questions included questions like state 8 physiological indicators of impending death. So we have factors like decreased level of consciousness, irregular or slowed breathing, like the chain stroke respiration, decreased blood pressure, weak or absent peripheral pulses, cyanosis or mottling of the body, reduced urine output, cold and clammy skin, loss of appetite and difficult in swallowing, irregular heart rate, respiratory congestion or death rattle, decreased responsiveness to stimuli, fixated dilated pupils, like when we do the Doll's test, relaxation of sphincters, extreme fatigue or weaknesses, altered temperature regulation, and changes in the skin tag and appearances. Explain 4 classes of antiarrhythmic drugs. All right, drugs used to treat arrhythmias, right? Try to use abnormal ventricular abnormalities. So we have the class 1 sodium channel blockers. This one, they slow depolarization and conduction velocity. Examples include quinidine, lidocaine, and flecainide. We have class 2, these are beta blockers. They inhibit beta adrenergic receptors, reducing heart rate and contractility. Examples include propranolol, metoprolol. We have class 3, the potassium channel blockers. These are they prolong repolarization and refractory period. Examples include amiodarone and sotalol. Lastly, we have calcium channel blockers. This one, they slow AV node conduction and heart rate. Examples include verapamil and diltiazem. Explain 4 stages in acute renal failure. We have the initiation phase. This is the time from the onset of the injury and then until the renal function begins to deteriorate. Oliguric phase, this is decreased urine output, fluid retention, hyperkalemia, metabolic acidosis occurs. And this one we said one of the complications that can easily develop at this stage. We have talked of the pulmonary edema. Diuretic phase, this is a gradual increase in urine output but with potential electrolyte imbalance as the kidney recovers. Lastly, we have recovery phase where we have renal function normalizing with gradual improvement in the GFR. You're supposed to illustrate 3 phases of bacterial dialysis. Bacterial dialysis has 3 steps. We have the fill stage, that's the first stage, or inflow stage, where the dialysate is infused into the peritoneal cavity through a catheter. Then the dwell phase, where the dialysate remain in the cavity, allowing for the diffusion and osmosis to remove waste products and excess fluids. And then lastly, the drain, where now it's used dialysate now is removed, carrying waste products and toxins. Describe 4 stages of ventricular breath cycle. Okay, so a ventricular breath cycle consists of the 4 stages, abbreviated as TACE. We have the trigger phase, where the ventilator detects the need for a breath, either through the patient effort, so that we say this is patient triggered, or a preset rate, so that this will be time triggered. Remember, proper sensitivity ensures there is synchrony. Respiratory phase is number 2, where the ventilator delivers a preset tidal volume or pressure, optimizing oxygenation and lung expansion while avoiding barotrauma. We have cycling phase. This represents the transition from inspiration to expiration and is determined by volume, pressure, time, or flow. Proper cycling prevents diaphony. Expiratory phase is the last phase stage, and here the air leaves the lungs passively. We have PEEP, maintaining alveoli patency and monitoring to you need to monitor to prevent air trapping, and also the auto PEEP. So we have those 4 stages of ventilator breath cycle. Describe any 4 types of mechanical ventilators. So we have different types of mechanical ventilators. We have volume controlled ventilators, which normally deliver a preset volume with each breath regardless of the airway resistance. We have pressure controlled. They deliver air until a preset pressure limit is reached, which is with a variable tidal volume. We also have like the CPAPs, which maintains constant positive pressure throughout the respiratory cycle to prevent airway collapse. We also have the BPAPs, the bilevel positive airway pressure. This one provides 2 pressure levels, higher for inspiration and lower for expiration. 4 types of heart blocks. Could talk of the heart degree heart block, second degree heart block type 1, that's the Mobitz, type 1, the Wenkenbach. Then we have second degree heart blocks type 2, and then lastly now we have the 3rd degree or the complete heart block. Complications associated with hemodialysis are a number. Also, we have hypotension, we have infection, muscle cramp, and disequilibrium syndrome. How do we perform the Allen test? Remember, the Allen test evaluates the patency of the radial and the ulnar arteries before arterial cannulation or blood sampling, like the ABG. So we ask the patient to clench their fist tightly, or just compress the hand if they can't. And this is just to force blood out of the hand. From there, we Occlude both the radial and ulnar arteries using the fingers. Then ask the patient to relax the hand, which will appear pale, right? So you release pressure from the ulnar artery while keeping the radial artery compressed. You observe the hand, right? You observe the hand. So normal will be if the hand flashes pink within 5 to 15 seconds, indicating adequate ulnar circulation. Delayed or absent color return suggests inadequate ulnar artery perfusion. We have types of critical care units outside the hospital, the intensive care unit. You could talk of intensive cardiac care unit, the neonatal intensive care unit, the burn unit, the step down unit. Now to the long answer section. You could be given Mrs. B, 45 years old, 45-year-old woman is admitted in the critical care unit with the diagnosis of malignant hyperthermia. So you identify 5 nursing diagnoses for Mrs. B and outline the pathophysiology, right? You could have infective thermoregulation, impaired gas exchange, risk for decreased cardiac output, acute pain, anxiety. Remember, malignant hyperthermia starts with a triggering agent, then leads to calcium dysregulation, muscle hypermetabolism, metabolic derangements, and lastly, systemic effects. In terms of management, there is normally immediate discontinuation of triggering agent, administer dantrolene sodium, hyperthermia management, maintain airway and ventilation, correct metabolic imbalances, prevent complications, monitor and support cardiovascular functions, lab and diagnostic monitoring, patient education and genetic counseling, and lastly, critical care team collaboration. Concerning anaphylactic shock, can you explain the pathophysiology of anaphylactic shock and describe the management of anaphylactic shock? Okay, so we start with triggering agent, massive histamine release, systemic vasodilation, increased vascular permeability, and then you have airway and smooth muscle effects, cardiovascular collapse, and multi-system involvement. In terms of management, there is immediate removal of the allergen, securing the airway, administering epinephrine, fluid resuscitation, antihistamines, the bronchodilators, corticosteroid, vasopressors, monitor and reassess. Need to prevent future episodes by educating the patients about the allergen avoidance, prescribe and teach the use of epinephrine auto-injector, the EpiPen, and then refer for allergy testing and possible desensitization therapy. In terms of multidisciplinary collaboration, you need to collaborate with allergists, emergency care providers, pharmacists to ensure comprehensive care and follow-up. So we have Mrs. T. Mrs. T is admitted to critical with the acute renal failure. So looking at nursing priorities for acute renal failure, we have fluid volume excess, impaired gas exchange, and electrolyte imbalance, risk for infection, impaired skin integrity. Pathophysiology, we have the initiating event, which leads to decreased renal blood flow that causes tubular injury and accumulation of waste products, and then fluid and electrolyte imbalances. In terms of management, you identify and treat the cause. You administer fluids cautiously in the pre-renal acute renal failure to restore volume. You administer calcium gluconate, insulin with glucose, or sodium bicarbonate to manage hyperkalemia. You use diuretics to enhance fluid elimination if urine output is present. You initiate hemodialysis or continuous renal replacement therapy if indicated. You monitor fluid balance, urine output, electrolytes, and renal function tests. You also provide a low protein, low sodium, potassium restricted diet to reduce metabolic load on the kidneys and prevent infection through use of aseptic techniques. For the DKA, we normally have insulin deficiency that leads to hypoglycemia and gluconeogenesis, result into lipolysis and ketogenesis, metabolic acidosis, osmotic diuresis, electrolyte imbalance, and compensatory mechanism. In management, we do fluid resuscitation, insulin therapy, electrolyte replacement, acidosis management, monitor and reassess, address underlying cause, prevent complications, educate, and do the follow-up. Okay, guys, that marks the end of the presentation.